o'clock and we should get started. I'll do the introduction. I have the great pleasure of introducing today Dr. Elizabeth Montgomery, who has graced us with her virtual presence for our grand rounds. She really doesn't need an introduction, but for those who do not know her, she started her career in the Army. And then progressed to Georgetown and Georgia.
Hi, how are you?
I'm good. How are you?
Can you mute yourself?
For COVID test?
Yes.
Okay. Have you taken one?
And then progressed to Johns Hopkins, where she was for over 20 years, and just recently, this past summer, moved on to the University of Miami, where she continues her legacy as professor of pathology and vice chair of anatomic pathology. Her first paper was written in 1982, and since then, she has acquired 345 manuscripts, peer-reviewed manuscripts, a ridiculous amount of book chapters and books also, so 67 book chapters and 26 books, and many, many milestones through this amazing career that really is, I'm in awe of her and what her achievements are. And I can't wait to hear her talk. And I hope I did her some fairness in this short and sweet introduction.
Thank you very much for that very generous introduction. So let's get started. For those of you who do GI pathology, this is my nerdy little set of favorite stomach lesions. For those of you who don't, well, at least I have cute pictures. So here we go. This is a short bio about me. I just like it because I look way better in that picture than I do in real life. So there we go. So we're going to start to talk about my favorite GI lesions with the things that can cause atrophic gastritis, i.e. loss of the normal stuff that you're supposed to have in the stomach, and sometimes with metaplastic replacement by other stuff. And the one that we see all the time in daily practice is the atrophic gastritis associated with Helicobacter pylori, but then there's another type that's called the autoimmune type, and that's the one that nobody ever gets taught about in residency. I certainly didn't, but then I've learned, so I want to share it. So H. pylori gastritis we all know and love. I'm just going to use it as a springboard to contrast it with the other type that I find much more interesting. So, of course, there are a couple of dudes who got a Nobel Prize for rediscovering H. pylori, Warren and Marshall, many, many years ago. And Warren was the pathologist, the nerdy, dorky pathologist, and he worked with Barry Marshall, a gastroenterologist. And the reason they got their Nobel Prize a few years back, well, actually probably close to 20 years back, but 20 years after they wrote their paper, is because H. pylori has huge consequences. Now, if you have H. pylori for a really long time, you're likely to be asymptomatic, but some folks have dyspepsia, and some folks get stomach ulcers and duodenal ulcers. There's a weird thing wherein the H. pylori is postulated to preferentially suppress cells that, the D cells, leaving the G cells with produce gastrin unopposed, and then you produce excess acid, which pours into the duodenum, and you got an ulcer. Sort of a soft theory. After many, many years, you can also start losing your mucosa, and you get what's called atrophy, and then you get metaplasia, typically intestinal. And of course, we all know that these folks are at increased risk for intestinal type adenocarcinoma, mucosa-associated lymphoid tissue lymphoma. I still remember the brouhaha when folks figured out you could cure a lymphoma by eradicating organisms, so pretty cool. And there's a link to autoimmune gastritis in the susceptible host based on epidemiologic data. So everybody who signs out surgical pathology knows that if you see a biopsy that looks like this at low magnification, this is oxyntic mucosa, the parietal cells are pink, and there's a band of blue at the surface. In all likelihood, the patient has H. pylori gastritis. And here we are at high magnification. I'm trying to show some neutrophils here, some neutrophils actually in the epithelium. And those of you who are real nerds can make out some faint organisms here. But the point is that the gastritis is superficial. This is a beautiful image from many years ago using a technique called Stemmermann's technique, and a solution is poured on the open stomach that turns everything with intestinal metaplasia red. So you would expect down here where the beginning of the small bowel is to be red because it's intestinalized. This is the gastric body, and this is the transition zone between the body and the antrum. And you can see there's a lot of intestinal metaplasia. Before folks figured out about Helicobacter pylori, this was called environmental metaplastic atrophic gastritis. And we realized that it was this soil in which we could find carcinomas. So beautiful example of H. pylori related atrophy with intestinal metaplasia, mostly at this sort of junction, this transition zone. Notice that it's worse here than in the actual antrum, and a relatively spared body. It wasn't actually until 2008 that it was proven that you could eradicate Helicobacter pylori and prevent gastric cancer. So it seems intuitively obvious, but it took a long time to show it. And this was in a Japanese cohort. And of course, people in Japan are at very high risk for gastric carcinoma for probably multifactorial reasons. And you'll notice they started this study and they had a whole bunch of folks who all had Helicobacter pylori and itty bitty little stomach cancers that could be treated endoscopically. Half of the folks they gave antibiotics to and eradicated the H. pylori, and the remainder they let go on their merry way. And they had to abandon the study at year 3 because they had too many new cancers in the folks who didn't have eradication. And then at that point, they just eradicated everybody. So very, very provocative. A similar study was done and published in a different holy book. Notice this one was published in the Lancet. This holy book, the New England Journal, had a more recent paper, 2018. And you can see that cancers were more likely in patients who had, new cancers were more likely in folks who had incomplete eradication of organisms. Okay, so that's H. pylori. That's one side of the coin. We're going to flip over the coin and look at autoimmune gastritis. So I have a little cartoon here, and on the right, you remember the red from the intestinal metaplasia. You can see that early in the course in patients who have H. pylori, you mostly get, I got to make my pointer work, you mostly get your intestinal metaplasia at the transition zone, and gradually it fills in the entire antrum and even percolates into the body. On the other hand, in well-developed autoimmune gastritis, notice that there's not much intestinal, or there's none in the cartoon, that's a perfect situation in the patient with autoimmune gastritis, but there's lots of it in the body. So very, very different profile. And these are some of these ancient specimens with a special technique. This is the gastric body, lots of intestinal metaplasia in autoimmune gastritis versus antro-predominant intestinal metaplasia in H. pylori associated gastritis. And there's a little cancer here in this case. And you can see the patients only had an antrectomy. All right, so autoimmune gastritis, what happens? Well, you are unlucky enough to have autoantibodies to your parietal cells or intrinsic factor. Generally, these patients aren't found to have H. pylori. So in a well-developed case, the findings are restricted to the gastric body. There's usually diffuse metaplasia in a well-developed case with lots and lots of loss of oxyntic glands or atrophy. And in these patients, the antrum looks fine. And in fact, it can be hyperplastic. It usually has a reactive gastropathy look, but the endocrine cells are the important ones. So you'll recall that the G cells live in the antrum. And they just live in the antrum. They produce gastrin. Gastrin stimulates ECL cells, enterochromaffin-like cells in the gastric body. So the gastrin stimulates other endocrine cells in the gastric body, which in turn cause the parietal cells to secrete acid. They do it by secreting histamine, and then the histamine makes the parietal cells secrete acid. So very, very important feedback loop, and we'll touch into that more. So this is an esophagectomy. This is an autopsy specimen. The patient didn't die from her autoimmune gastritis, but she did have atrophic gastritis. So you can see there's still some gastric folds in the antrum, but the body has such attenuated mucosa that you can make out all the little vessels, and it really does look flat. Very, very nice finding in an elderly lady. Lady, yes, most patients with autoimmune gastritis are female. So just to sort of do a compare and contrast, on the bottom we have normal body mucosa or oxyntic mucosa. The parietal cells are kind of in this layer, the chief cells down here, here are the foveolar cells, and here's the autoimmune gastritis. It's a blue biopsy, you can't see any parietal cells, and it's about half the thickness of the regular mucosa. And the endoscopist can sometimes pick up on this, but usually they don't. So on a biopsy, I've taken these pictures so that the bottom of the image has the muscularis mucosae, and on the left we have the autoimmune gastritis with total loss of parietal cells, and on the right we have the normal, and you can see that it's thicker. So let's kind of look at how autoimmune gastritis looks. So let's make this our patient. We'll make her a 61-year-old lady, and here she is. And this is her antrum. Notice that it's very, very well organized. You have your antral glands here. Here's the middle stuff. This is where the endocrine cells live, the G cells. And this is the surface. And this has what GI people will call chemical or reactive gastropathy, often from non-steroidal anti-inflammatory drugs or bile reflux. Okay, no problem. Not very exciting. Not too far off normal. Here's the same patient's body. Oh my gosh. The parietal cells are gone. And what we see is intestinal metaplasia and so-called pyloric or pseudopyloric metaplasia. Some people call it pseudopyloric because this type of epithelium does not express gastrin if you do a Gastrin stain, and there's no gastrin found there. Okay, so loss of parietal cells, intestinal metaplasia, pyloric metaplasia, and bottom heavy inflammation. Not much up there. For whatever reason, patients with autoimmune gastritis, they lose all their parietal cells, have a tendency to have these pockets of pancreatic metaplasia. So that's kind of a clue if you have a funny looking stomach biopsy. Of course, it's very common to have pancreatic heterotopia in both the cardia and in the antrum, but usually you don't have that in the body. So if you see this on something that's from the body, it's a clue to consider autoimmune gastritis. And here it is at high magnification under oil because everyone wants to see those lovely, lovely little zymogen granules. All right, so if you do a Gastrin stain on the gastric antrum, you'll see the G cells. And you can see that they're more or less in a line, kind of right between where the foveolar surface cells are and then the antral gland. So they're very, very methodically placed. This, on the other hand, is a Gastrin stain from the body. Now you'll notice that there might be one or two, and that suggests that the biopsy was taken from the transition zone. On the other hand, if you do a chromogranin, you start to see enterochromaffin-like cell or Ecl cell hyperplasia. So if it makes a nodule, it's called nodular. See, I can do this. And if it makes a line of 5 or more cells, it's called linear. And this happens because the G cells in the antrum notice that there is no acid being secreted in the gastric body. They pour out gastrin, and the gastrin stimulates the Ecl cells, and they work harder and harder and harder, but they can't make any acid happen because there are no parietal cells to do that for them. So they become hyperplastic. So very, very important. Here's another example of that Ecl cell hyperplasia. So here it is very much linear, not quite making a nodule. There's still a few intervening mucus secreting cells. So what happens if you're one of the guys who has autoimmune gastritis? Well, you don't make acid. You can't absorb vitamin B12. So you're at risk for pernicious anemia, which is a neurodegenerative disease. You have very high serum gastrin. Your risk of gastric cancer is increased with all those metaplasias. You probably don't have to worry too much about ulcers because you don't have any acid, unless, of course, you take a lot of non-steroidal anti-inflammatory drugs. So when I was first learning about autoimmune gastritis, I was told that it was a disease of blonde-haired, blue-eyed ladies. And they do get it, but everybody else gets it too. It's actually an equal opportunity disease as far as racial characteristics go, but it definitely has a big female predominance. Now you can diagnose autoimmune gastritis when it's not all the way developed, when you only have incomplete parietal cell loss. And what you'll see is areas of apoptotic damage in parietal cells, and you'll see these little pockets of pyloric and pancreatic metaplasia. But even at this stage, with incomplete loss of parietal cells, you'll find the enterochromaffin cell hyperplasia. The really cool thing is that if there's still H. pylori present, or if you find H. pylori in this setting, there's some data that suggests that if you eradicate the organisms, you can slow down the parietal cell loss. So that's good. All right, let's look at an example of evolving autoimmune gastritis. So this is the highly organized antrum. Very nice. And this is the gastric body of the same patient. So notice it has bottom heavy inflammation, and you can see a parietal cell in the center. It's being beaten up by lymphocytes. They're trying to eat it up. And there's a whole batch of parietal cells here that are being gobbled up by lymphocytes. Here's an apoptotic cell. Here's another one. So somebody's eating this lady's parietal cells. And of course, that's the lymphocytes, the T lymphocytes, and they're in there having a feast. And here's that whole phenomenon at higher magnification. I'm trying to show you right here an apoptotic parietal cell. And in this same case, this is the chromogranin stain. And notice that there's a very disorganized arrangement of staining, but it's producing nodules and then areas with cells in a line. So, and if you don't have a Gastrin stain to prove that you're in the body, you can still sort it out just by looking at the pattern of chromogranin staining. Plus, the chromogranin stain will stain, let me go back. The chromogranin stain will pretty much mirror, if you had a Gastrin stain, this very orderly arrangement of where you find the labeling. All right, now in this particular case, this is an H. pylori immunostain. I was too dumb to find them on the H and E, but there was acute inflammation, so I added the stain, and this patient has Helicobacter hanging around, which may or may not, probably did, trigger this autoimmune response. So here's a compare and contrast between H. pylori gastritis involving the gastric body and the kind of pattern you might see in evolving autoimmune gastritis. So on the left, we can see this superficial band, if I can make the pointer work, whereas there's kind of uniform distribution of the inflammation with more damage down below to the parietal cells in evolving autoimmune gastritis. So what do you need to assure? So make sure, if you're a resident, that you do figure out how to diagnose autoimmune gastritis. I certainly wasn't taught when I was a resident. Clinicians also don't know what it is. So we've begun to just report autoimmune gastritis / pernicious anemia pattern. Back when I worked at Johns Hopkins, we saw autoimmune gastritis in about 2% of our in-house biopsies. The population in Miami is very different. I think the figure is about 5%. And interestingly, when I was in Baltimore, I published quite some time ago kind of an overview of autoimmune gastritis in our population, and I should have given the reference. And we noticed that there seemed to be a higher percentage in Latinas than in kind of standard white bread middle Atlantic US population. And but we didn't have enough Latinas in our population to have statistical significance. Well, there are plenty of Latinas in Miami, and I think in this population, about 5% have autoimmune gastritis. But do think of it when the biopsy of the body looks like antrum with bottom heavy inflammation. So why this lengthy preamble? Well, it relates to neuroendocrine tumors. Here's the kind of report that I've been doing for autoimmune gastritis. I point out that these patients are prone to both iron deficiency anemia and pernicious anemia, and that is a true fact. They can't absorb iron very well because their gastric pH is rotten for it, too high. And they're also at risk for various epithelial neoplasms and kindly correlate with certain serum studies. All right, so after many, many years of this enterochromaffin hyperplasia, guess what? It can bust out into a well-differentiated neuroendocrine or carcinoid tumor. Since well-differentiated neuroendocrine is a mouthful, even though it's the preferred term, I'm going to show my age and talk about carcinoids. So this is an example of a gastrectomy, rather radical. Her stomach just didn't work at all in a patient who just had so many of these autoimmune gastritis-associated carcinoids that her stomach basically was non-functional. Here's her antrum, doesn't look too bad. And then there's this entirely lumpy, bumpy gastric body. Luckily, this doesn't happen too often. So let's look at a case. A partial gastrectomy was performed for a cancer in a 51-year-old or 55-year-old woman with a history of type 1 diabetes. So she had, if you will, kind of an autoimmune diathesis. So here it is. I think the surgeon overdid it a bit, but that's neither here nor there. So here's muscularis propria, submucosa, lesion, that's at the junction of the mucosa and the submucosa, a great place for a carcinoid because that's where the endocrine cells live. And you can see that this gastric body's flat mucosa is very blue, so that's not right. So here's the tumor. So it's a type 1, the old type 1 carcinoid, the type associated with autoimmune gastritis in a fully grown woman with an autoimmune type history. Now notice it's got a weird configuration, and these often get mistaken for adenocarcinomas. So keep that in mind. Don't go down the tubes. Here's her background flat mucosa, and I've circled ECL, enterochromaffin-like cell hyperplasia. I've circled some pseudo-pyloric metaplasia, and of course it's pretty easy to spot the intestinal metaplasia. So here gets into something that's kind of fun. When does it stop being ECL cell hyperplasia and become a type 1 carcinoid? There's an enormous literature on this, mostly out of Italy. And in Europe, you can get a PhD for writing 5 papers on the same topic, and they can just be regular old search path papers. They have to be proper studies, not case reports, but it's a very different system from that in the US. And you know, they've got all these folks who need to get these PhDs, and so they get to count endocrine cells. So there's this massive literature. It's interesting, like when does it stop being hyperplasia and become neoplasia? But it's of no practical value. Fascinating, no practical value. Some people use a cutoff of 0.5 millimeter for carcinoid, and other people use a cutoff of 5 millimeters or 0.5 centimeter. I don't worry about it. If the endoscopist sees a bump in a patient with autoimmune gastritis and biopsies it, it's a carcinoid, and the patient's going to do fine. The reason I'm so cavalier is because even full-fledged carcinoids never hurt anybody. They almost never spread to lymph nodes. I've only seen it once in a really, really embarrassingly long time. And I have never experienced patient death from a type 1 carcinoid. But it's fun for research. So of course, many of us were not taught to diagnose autoimmune gastritis. And of course, if you give a report that says that our poor internal medicine and family practice colleagues have to see a patient approximately every 3 minutes, and if you just write autoimmune gastritis, they don't even know that they have to think about anemias and poor absorption of iron and pernicious anemia. They just don't. And sometimes, and less as our surgical colleagues become bigger thinkers and work hard about that, sometimes surgical colleagues want to overdo the resection for such tumors. So this is an aggressive resection, again, for a type 1 carcinoid. You can see the bottom heavy gastritis in the background, and here's the lesion. And notice it's right at the junction of the mucosa and submucosa. So this is the junction of the tumor and the non-neoplastic stuff. And you can see it's a hot mess. This is a combo synaptophysin Ki67. The Ki67 is brown and the synaptophysin is red. So you can see how lovely the tumor is. And this is the background mucosa. And in this case, you can actually see the Ecl cell hyperplasia very easily just on the H&E. You'll notice the India ink tattoo so that the colleague in surgery would know where to cut. And this is that same preparation with the red stain being the synaptophysin, showing us the enterochromaffin-like hyperplasia. The brown is a Ki67, and obviously that's just the proliferation compartment of the stomach. So here's another type 1 carcinoid. I don't know about you, but I could easily get fooled by this and think it's a spindle cell lesion, or, well, that would be my main concern. And they often do look really strange. So always pay attention to the background flat mucosa. This, on the other hand, is a problem with these so-called type 1 carcinoids. They are always indolent. Metastases are rare for them and deaths are truly exceptional, but sometimes, about 20% of the time, they'll have the proliferation index of a grade 2 well-differentiated neuroendocrine tumor, and then you have to write a long note. So I usually don't even bother to get the Ki67 in these type 1 carcinoids. And then, of course, if I get a knucklehead who insists that I do it, I do it. And then if it looks like this, I have to write a note, and I'm lazy. Okay, let's look at another case. This is case 2. Slide A is from the duodenum and slide B is from the stomach. Let's think of a syndrome. Woo, woo. All right, A, duo. There's the lesion in the center. Here it is at very high power, and it looks like a neuroendocrine tumor. Here is a stomach nodule, same patient. High power, looks like a neuroendocrine tumor again, but it looks different from the other one. It has good neuroendocrine nuclei, but very different looking cytoplasm. Here's a Gastrin Stain from the small bowel lesion. And here's a Gastrin Stain from the stomach lesion. So hopefully you guys are all thinking about a syndrome. Does anybody dare yell it out?
Zollinger-Ellison.
Yes, somebody is all over it. Yes, that is indeed Zollinger-Ellison with a duodenal gastrinoma and a gastric carcinoid tumor of Ecl cell type. And this is the so-called type 2 carcinoid. And this is the tandem stomach of that case. I showed you a very ancient case so that I could show you this. You'll notice that now there is not loss of parietal cells. There is massive hyperplasia of parietal cells, and the mucosa is just as thick as the muscularis propria. So very, very striking. Nowadays, of course, you wouldn't see a gastrectomy in this situation, but this is a very old case. And here it is again. And you can see that the parietal cells go all the way up almost to the surface, which is very unusual. And we really don't get to see these beautiful findings now in the proton pump inhibitor era. And here we are at really high magnification, and you really don't in normal stomachs see these parietal cells way the heck up, kissing the foveolar surface. This happens to be another image of the gastrinoma that produced this massive parietal cell hyperplasia. And you'll notice that it's metastatic to a lymph node. And years ago, there was this giant literature, well, no, medium-sized literature about primary gastrinomas of lymph node. Oops, well, that's just because the colleagues didn't know that you had to cut the heck out of the small bowel to find the teeny-weeny little gastrinoma of the small bowel that produced these massive lymph node metastases. Type 3 net. So we've done type 1 and type 2. The type 3 has no autoimmune gastritis backdrop, no Zollinger-Ellison, i.e. no gastrinoma, but the common denominator is there's no hypergastrinemia. These are believed to be a bit more aggressive than type 1s, with about a third dying of, these are substantially more aggressive than type 1s, with about a third dying of disease and metastases in 70%. Remember, almost no metastases for type 1. That's truly exceptional. The data are not very good on type 2, the ones associated with Zollinger-Ellison, because the patients are likely to die of their pancreatic neuroendocrine tumors or their small bowel neuroendocrine tumors, but they're considered fairly indolent. Here's a type 3 carcinoid. So what do you see? You see that the surrounding oxyntic mucosa is normal. There's no gastritis here. Now, you might have a little gastritis right in the area around the tumor, so be cautious in interpreting this stuff. I know I've gone down the garden path in this situation. This is an endoscopic submucosal dissection of this lesion performed by one of my former colleagues at Johns Hopkins. I think she did a beautiful job. And here you can see not that lesion, but another one. So you're pretty sure already that this is a so-called type 3 NET or type 3 carcinoid because you see intact oxyntic mucosa. There is one little strange exception that I'll discuss in a bit. So notice how weird this thing is. It's making funny tubules and just has a very odd morphology. So really these type 1 carcinoids can look weird. Here's another one, and this one was so nasty, it actually was a spindle cell lesion, and colleagues got burned because they did a kit and it was positive, and their keratin was weak, so they got fooled and called it a gastrointestinal stromal tumor. The surgeon thought something was off, so it ended up undergoing re-review, and the surgeon had been smart enough to get a serum gastrin, and it was negative when she did her resection, or before she did her resection. Okay, so here's that one at high power, a real setup for a burn. It really looks very much like a mesenchymal lesion. And here's the intact parietal cells in the background. This happens to be the AE13 pankeratin on this case, and you can see it's very, very weak. A follow-up CAM 5.2 really highlighted everything very, very well. This happens to be the chromogranin. I think this stuff up here is non-specific biotin staining and oxyntic mucosa, but there's no Ecl cell hyperplasia here. And here's the chromogranin showing the tumor staining. So sort of moving along, true high-grade gastric neuroendocrine carcinomas can also be very rarely encountered. Generally, they are metastases from someplace else, such as the lung. And to find out whether they're primary in the antrum or in the stomach, you really have to go through the drill of sending the colleagues for imaging. TTF1 antibodies used to sort of stain all the high-grade neuroendocrine carcinomas wherever they came from. There are now recently some more refined antibodies that seem to be more restricted to pulmonary high-grade neuroendocrine carcinomas. So this is just another gastric neuroendocrine carcinoma. I've just got the arrow on a mitosis. And of course, you can often see very strong, strong synaptophysin. So if you want to make sure that you do a good job when you get a gastric neuroendocrine tumor, make sure you do know how to diagnose autoimmune gastritis. I've given you the sort of likelihood of finding it. It's probably going to be similar to the Hopkins population in Alabama, maybe slightly higher depending on your mix of patients, but you'll see it. You should see it in a busy service once or twice a week. And do think of it when you have bottom-heavy inflammation. Now, there are a few wrinkles in all these gastric carcinoids, and there's been a very nice recent paper from last December from Dr. Ma, who is at the University of Pittsburgh, and I've noted the reference below. So she pointed out a very interesting thing. So we've mentioned that type 1 and type 2 carcinoids are probably indolent, and mostly type 3 carcinoids are bad. But what these colleagues did is they picked out a subset of people who've been taking proton pump inhibitors since the beginning of time and found that, oh my gosh, these folks actually have Ecl cell hyperplasia. And based on their follow-up in a limited number of patients, these seem to be indolent. So a very recent, very interesting observation. I have not played around with this yet, but it's kind of cool. There's also a very rare so-called type 4 carcinoid. It's not well established. It didn't make it to the last World Health Organization book, But there is a very small subset of patients who have hypergastrinemia, but they don't have autoimmune gastritis, and you can't find a tumor. And they actually seem to have defects of acid secretion, and their parietal cells don't work. The theory is that they have an inactivating mutation of the ATP4A gene, and that happens to encode the hydrogen potassium ATPase that the parietal cells need to produce acid. So everything looks histologically normal, but yet they have this horrendous hypergastrinemia, and you can't find a tumor. So rare, evolving entity. So this paper is very nice, the one that's noted here, because it kind of talks about a global sweeping bit about all of these types of carcinoids. So we've talked a little bit about gastric hyperplasia. We talked about oxyntic hyperplasia. I showed you pictures. Now I want to show off some pictures of foveolar hyperplasia. And of course, the eponym is Menetrier's disease. So of course, patients with Menetrier's disease have this massive, usually gastric body, foveolar hyperplasia. They pour out mucus. They have glandular atrophy. They absolutely pour this stuff out, and the patients lose protein and become ill. If you look at a biopsy, the patients have glandular atrophy. There's not much inflammation, and it's generally limited to the body and fundus. The only problem is that you cannot diagnose it on a biopsy unless you've got the clinical info. You'll need to know that there are these massive folds. You need to know that the patients have lost protein, and then you need to know that there's no normal intervening mucosa between the Menetriers or disease lumps, because hyperplastic polyps look very similar. This is from Menetriers' original paper. Isn't that cute? And this is a photograph from more recently, although it's still a vintage photograph. I pilfered it from the late John Yardley, who was at Johns Hopkins for many years. So you'll notice there's this massive hyperplasia. If we had a biopsy of this flat stuff between the lumps, it would be abnormal. But the antrum down here is spared. Obviously, this is the esophagus. I'm just proud that I know that. Here's another example of Menetrier's disease. So you can see the antral folds nicely. That's the beginning of the duodenum. And then there's this massive foveolar hyperplasia. Here it is fixed and cut. It's just insane. So hopefully you can see the layers. Here's the muscularis propria and the adipose tissue outside the stomach, and then this crazy foveolar hyperplasia. So we've kind of talked about the stuff that these folks have. Well, we've mentioned all these cool things. And here's what you might see on a biopsy. Now, if you know that the biopsy is from the body, then you know something's off. But I personally have very little precision in separating this from a funny hyperplastic polyp or just foveolar hyperplasia. You got to be on top of the clinical. The good news is that generally, if the endoscopist sees something that looks like Menetrier's disease, the endoscopist is calling you and asking for a rush protocol and going crazy. So you usually will get some indication that there's something terribly off. The pathogenesis is really interesting, and it's been exploited with modern modern pharmacology. But many years ago, it was discovered that folks with Menetrier's disease seem to have some issue with TGF-alpha, transforming growth factor alpha. And in fact, people made transgenic mice that overproduced TGF-alpha, and the mice had features of Menetrier disease. They lost acid production, they had massive foveolar hyperplasia, and they had all this mucus. And of course, if you remember your very basics, which I can barely do, TGF-alpha, of course, is in the epidermal growth factor receptor, EGFR family, and so you can target it. Yay! And in fact, folks did. And you can see that many 20-ish years ago, colleagues that included Kay Washington, who's a very well-known GI pathologist, and Bob Coffey, they were in the Vanderbilt Duke cluster of colleagues. They were able to figure out that you could use what was then called Erbitux, now it's called Herceptin, to settle down Menetrier disease, i.e. targeted therapy. So it's really, really cool. So you won't see these gastrectomies that I showed you now. So really, really a neat thing. Let's look at another case. Large gastric body polyp in a 72-year-old woman who had autoimmune gastritis for a squillion years. So here it is, and this is an entity with which this old lady is obsessed. And here's a different one, but high power. So hopefully you're all kind of wondering. Oops. And this is, of course, a pyloric gland adenoma, an entity with which I am obsessed. So that kind of puts me into a few comments on stomach dysplasia and polyps as we close out. So if you look at gastric things that we've called adenomas in a Western population, you can notice an intestinal type with intestinal differentiation. And notice I've said AKA, also known as polypoid gastric dysplasia. There's a gastric foveolar type. I just showed you a pyloric gland adenoma, and these can be sporadic or syndromic. And then there's kind of a rare one called the oxyntic gland or chief cell adenoma. You'll notice that pyloric gland adenoma and oxyntic gland adenoma have the same mutations, but they have different morphology. Well, a few years back, colleagues in Europe came up with the MAPS system, Management of Epithelial Precursors and Conditions and Lesions, or blah, blah, precancerous conditions and lesions of the stomach. In Europe, they always come up with a catchy name. We're too dumb to do that here in the US. They called it MAPS. And they introduced the concept of, wait a minute, guys, when you see these lesions, there's always background damage. So they're more like colitis-associated dysplasias. And they suggested that we call them lesions and that they're basically polypoid gastritis-associated dysplasias. And it's confusing because for years we've just called these things adenomas. So it's also confusing because that would make you think that a polyp with pyloric gland differentiation in a patient with autoimmune gastritis and pyloric metaplasia is in fact polypoid gastritis-associated dysplasia. But if you see the same polyp in a patient with familial adenomatous polyposis and no gastritis, then it's an adenoma. Well, yeah, conceptually they're different, but morphologically they look the same, and the same nonsense can apply if you see a polyp with intestinal differentiation. So let's look at some of that. So this was a polyp clinically that one of my endoscopy colleagues biopsied. It looks like a tubular adenoma of the colon, but you know it isn't because we've got this gastric stuff down here. They probably don't show well, but there were a few goblet cells in the lesion. So by kind of convention, this would be a gastric adenoma of the intestinal type. Here is a periodic acid shift Alcian blue, or PASAB. I think I can see a goblet cell in the polyp right here. And here's the flat mucosa in this same patient, and it obviously is atrophic and has intestinal metaplasia. I believe this is true antral. So, you know, okay. And here's the PASAB on that. You don't need to do it, but it's kind of fun to see it. This, on the other hand, is a true adenoma. This is a foveolar type adenoma. It's arisen in oxyntic mucosa with absolutely pristine qualities. There's no metaplasia, there's no gastritis. This is the type of lesion that's actually equivalent to the usual colorectal adenoma as opposed to colitis-associated polypoid dysplasia. So these are quite uncommon, and every once in a while you get to see one. Here's another sort of similar case. You can see that there's pure foveolar dysplasia here. It's probably low grade. It's sitting on top of a fundic gland polyp. I can't tell you whether this is a fundic gland polyp with surface low-grade dysplasia or a foveolar adenoma. Does it matter? No, because neither is likely to progress. Here's this one at higher mag. You can see there's absolutely pure foveolar differentiation. This is very uncommon. Here it is at higher mag, proven by a PAS Alcian blue. So the pyloric gland adenoma, and I'm just going to say adenoma, even if it's gastritis associated, was really defined in 2003 by a German colleague called Michael Fee. When he took all the stomach polyps in a very, very large institution and took out the fundus gland polyps, the most common one. So he threw those out. And once he threw all those out, pyloric gland adenomas comprised just under 3% of all gastric polyps. They were lesions of adults, and you'll notice that he had a massive female predominance. They were mostly in the gastric body, and he was able to demonstrate autoimmune gastritis in about a third, a little more than a third. Probably that's low. He may not have had flat biopsies in all of them. And in this defining series, he noticed that some of them progressed to cancer. We now know that these lesions have GNAS mutations. I can never remember what GNAS stands for, so I did the spell out here. And you see those same mutations, whether the polyps are sporadic or syndromic, and the syndrome where you see them is FAP, and they share these mutations with the weird, rare oxyntic gland adenoma or chief cell adenoma. So here's one. You see this ground glass cytoplasm, monolayer of nuclei, and there's not really good foveolar mucin, nor is there really intestinal. Now you'll notice there's a bit of intestinal differentiation over here in this one, but they mostly lack it. Here's another one, again, that monolayer of nuclei and ground glass cytoplasm. If you do a PAS Alcian blue, you don't get a crisply defined apical mucin cap. You get this more smudgy stuff that's not quite as sharp as what you see in a foveolar adenoma. So a number of years ago, I'm guilty of the image on the right. My colleague Zhongming Chen with us published an idea of how to grade the dysplasia in pyloric gland adenomas, and it was probably not a very good idea. But it was right around the time that everybody was freaking out about serrated polyps that could be precursors but lack dysplasia. So that was kind of stylish at the time. So we came up with the notion that pyloric gland adenomas could have no dysplasia, and then low, high with loss of nuclear polarity, and then of course carcinoma. More recently, colleagues have said, no, guys, you're being drama queens. Don't do this. Let's just lump all these guys and have low grade and high grade. Of course, a characteristic feature of pyloric gland adenomas is expression of mucin core protein 6. So just to compare pyloric gland adenoma and foveolar adenoma, on the left, ground glass cytoplasm, monolayer of nuclei, involves both deep and the surface. The foveolars are just on the surface, and they have this perfect apical mucin cap. This is a PAS Alcian blue from a different pyloric gland adenoma. It's a little bit of a funny stain, but you can see this is gastric antral mucosa. This one happened to be mostly in the duodenum, and you can see it really doesn't have much staining at all on PAS Alcian blue. This is a different one. You can see there's co-expression of MUC5 often in these with the MUC6. You don't really need to do these. It's kind of an H&E diagnosis, but it's fun if you have them. Here's one with high-grade dysplasia. It doesn't look as ugly as the high-grade dysplasia in intestinal type polyps, and your thing that makes you turn it into high-grade is simply this loss of nuclear polarity. And of course, here's a proper cancer arising in association with a pyloric gland adenoma. The last one is the rare, weird one, and that's the so-called oxyntic gland adenoma or chief cell adenoma. These were first described as adenocarcinomas by Japanese colleagues, and when I show them to you, you'll see why. And then we noticed that none of the patients in this initial series had any events. They all did great following endoscopic treatment. So we collected a bunch of them and said, guys, maybe you're being a little dramatic. Maybe we should just call these adenomas because patients all do really, really well. Why are you scaring them? But remember, in Japan, it's less of a, here you lose your insurance and there's all this drama. In Japan, everybody gets gastric carcinoma, so it's not a big deal. I think it's sort of a cultural thing. Anyway, so we said that. Then, with more observation and knowledge, there actually are rare ones of these that metastasize. There's one now in a report that isn't even published yet but generally they're very, very indolent. So sort of a compromise was proposed by this colleague, also from Japan, to call this oxyntic gland neoplasm and call them carcinomas only if they invade the submucosa. So almost like what we do with colon polyps. All right, so here's one of them. It doesn't involve the surface. It's down here, and it's comprised of all these really jagged glands, which is why the original description regarded these things as adenocarcinomas, even though there were no events. And you can see sort of trapped in the darn thing are a bunch of our parietal cells. Here's one. And they kind of mostly look like they have chief cell differentiation. And whether this is just, you know, admixed with normal or whether the parietal cells in this gland are a true component, I don't pretend to know. Here we are at higher magnification. Anyway, so here's a parietal cell in a deeper part. So maybe they are an integral part. These also stain with MUC6. And this is a key 67. And you can see really the only staining is in the proliferation zone of the existing stomach. Now here's a weird one that happens to have arisen in association with autoimmune gastritis in the gastric body. So you can see the parietal cells are gone. And this one's more of a pure chief cell adenoma. And here it is at higher magnification. This is a PAS Alcian blue from a different one. There's really not much of any staining in the lesion. And this is a MUC5. So these don't have MUC5 expression, so no co-expression. And this is the MUC6 of an oxyntic gland adenoma. So you get just MUC6. The pitfall with these is that you can get light synaptophysin staining. So I know sometimes when these come to me in consultation cases, colleagues are concerned that they're dealing with a neuroendocrine tumor, but they're not quite convinced. So very interesting lesions. Here's why it's legit that some of them are adenocarcinomas. Here's one that has poked into the submucosa. And here it is at higher magnification. And this one has more cytologic atypia. Of course, this was easily cured just endoscopically, and the patient has done very, very well. And here, this one is at really high magnification, and you can see it's a lot uglier than what I showed you before. So I'd like to close by reminding you of the consequences of autoimmune gastritis if nobody taught you about it. And you see atrophy of oxyntic mucosa, pernicious anemia as an end product, various gastric adenomas, either of the intestinal or pyloric type, since these are the metaplasias. Remember, philosophically, this is just polypoid neoplasia or dysplasia. You see the type 1 carcinoid tumors. I didn't, in the interest of time, I didn't bore you with all the hyperplastic polyps and adenocarcinomas that you can see, but those are the consequences, so it's worth recognizing. And with that, I close, and thank you very much. And now I try to close the presentation.
Great, thank you so much for that. So we have a few minutes for questions, if anybody has any. I think you definitely had the attendance award. I think I saw our number hit 90. Okay, good. Yes, please.
Hi, Liz. Deepti Dal here, GI Pathology. You know, in my understanding, when I diagnose autoimmune gastritis, you're right, clinicians don't understand that. And I want to know how many times in your patient population they do antibodies for parietal cells or intrinsic factor, and how do they follow these up? Do they ever do it? Is it important to do it?
So that's a great commentary. You know what, I cannot remember the percentage, but when I was at Johns Hopkins, I know my colleague Meredith Pittman and I published a thing about evolving autoimmune gastritis, and we were able to dig around, and we dug around in the charts and found out how often they got the follow-up, and I forget the percentage in that paper, but it was very suboptimal. It was way, way suboptimal. Colleagues here in Miami seem to be more onto autoimmune gastritis, and they do get the serology, and they do follow the patients the majority of the time. The follow-up, though, is iffy. So the European societies have recommended that you bring these people in and map them every 1 to 3 years, but based on very weak data. The US societies have been a little reluctant to come up with specific recommendations, but I know here when patients have really full atrophy of oxyntic mucosa, they do bring them in every 1 to 2 years, and they find stuff. And the thing they're likely to find.
Oh, sorry, my thing has stopped working.
We can still hear you though.
Okay. Okay. Anyway, so
1 to 2 years, and do they find stuff? Yeah. Did they find stuff that's going to kill the patient? Not usually.
It's hard to hear you, Liz.
So, yeah.
It's okay though.
Oh, I'm so sorry.
No worries.
Technology.
Also, there's another question. Have you ever seen Ecl cell hyperplasia in H. pylori gastritis? I know you have seen H. pylori in some autoimmune, but can Ecl cell hyperplasia happen with just H. pylori gastritis?
Well, it seems like we're talking about the same thing from different angles. If you believe the theory that in the susceptible host, H. pylori can trigger autoimmune gastritis, that would get you Ecl cell hyperplasia. So I think we're talking about the same thing from different angles. The ones I've seen that had H. pylori and Ecl cell hyperplasia also had some metaplasias and parietal cell loss. So I suspect we're talking about the same thing from different angles.
Right. Thank you.
At least the microphone camera thing didn't happen until after your talk. So.
Yeah, I'm really sorry. Yeah.
No worries. We got to hear the main part. Are there any other questions? Okay. Well, thank you so much for joining us. There was a comment in the chat, and this is true for so many of our visiting speakers. We definitely hope to be able to do this again in person someday, because I know there are some people that definitely wanted to meet you, and there's always some good food to be had in Birmingham, as well as good colleagues to talk with. So hopefully in the future we can make that work.
All right. Well, thank you for having me. I'm sorry you can't see me waving goodbye.
No worries. Thank you for the wonderful talk.
Enjoy the day, everybody.
Bye. Thank you, everyone.